Morning, everybody. I'll be talking about isolated pediatric third nerve palsy in children, the clinical, etiological, and the neuroimaging profile. I have no financial disclosures and no conflicts of interest. So, isolated third nerve palsy in children is rare, and about half of these cases are reported to be congenital, with another half being secondary to trauma, neoplasms, infections, and so on. And congenital cases may present with complex features since they represent a part of the spectrum of cranial degeneration disorders, and they may be difficult to differentiate from other acquired causes, some of which can be life threatening as well. And therefore, neuroimaging is considered mandatory in all these cases. The lacunae in this field include the relatively smaller case series in existing literature and the low yield of neuroimaging with a large proportion of undiagnosed cases and a poor distinction between congenital and acquired causes. There is also an absence of a defined protocol for ordering neuroimaging in these cases. So, the purpose of the current study was to analyze the clinical features, the neuroimaging findings, and the etiological profile of a large number of isolated pediatric third nerve palsy cases presenting to our tertiary care referral center, and to come up with guidelines for defining the neuroimaging requisition in these cases. This was a retrospective review of the electronic medical records carried out at Jasti V. Ramanamma Children's Eye Care Center, L.V. Prasad Eye Institute, Hyderabad, spanning a duration of 8 years, wherein we included all patients under the age of 16 years with a diagnosis of congenital or acquired third nerve palsy and excluded those with an alternate final diagnosis and those with coexisting other motor cranial nerve palsies. So these were the results. 131 case files met the inclusion and the exclusion criteria, of which 64 were congenital and 67 acquired, with the congenital cases presenting on an average 2 years prior to the acquired onset cases and tending to have a worse logmar visual acuity, which can possibly be attributed to the dense amblyopia seen in these eyes. While the deviation and the motility limitation were not seen to be significantly different between the two cases, there were some differences with regards to the severity of the ptosis, the presence of Marcus gun jaw winking phenomenon, and the prevalence of aberrant regeneration at the presentation and the final follow-up. Also, interestingly, there was a progression noted in 14% of congenital cases, though this was significantly more in the acquired onset cases. So with regards to pupillary involvement, this was seen in 40% of congenital cases versus almost twice the number in the acquired cases, and most of these were in the form of a mid-dilated, poorly constricting pupil. Interestingly, a meiotic pupil was also noted in about 8% of congenital cases and none in the acquired group, and all of these 8% cases had a hypoplastic or an aplastic third nerve on the neuroimaging. These are the neuroimaging results of the congenital cases. A high-resolution Fiesta scan, that is a fast imaging employing steady-state acquisition scan of the third nerve, showed an aplastic or a hypoplastic third nerve in 54%, whereas other associated abnormalities such as a faces syndrome or corpus callosal agenesis was seen in additional 12%, with the overall yield being 66%. The orbital imaging showed muscle thinning supplied by the third nerve in variable distributions. And with regards to acquired cases, the largest proportion were seen to be post-traumatic, followed by inflammatory and compressive lesions. 12% of the cases did not yield any positive findings on the imaging, where another 12% showed an isolated schwannoma or neuroma of the third cranial nerve. Now, this was an important cause that was seen in our series. These cases were picked up as an isolated tiny nodular or fusiform enlargement of the third cranial nerve, as seen in this image here, which shows intense post-contrast enhancement and a T2 hyperintensity. So this is one prototype case showing progressive exotropia and ptosis, which was initially suspected to be a congenital third nerve palsy because of the muscle thinning seen on the orbital imaging, and the Fiesta scan revealed the schwannoma. So in summary, we saw a slightly higher proportion of acquired than congenital cases, which has also been reported previously. Pupillary involvement was seen more often in acquired than in congenital cases, which had a small proportion of a meiotic pupil as opposed to a mydriatic pupil. The yield of neuroimaging was seen to be higher than what has been previously reported using Fiesta sequence imaging for the oculomotor nerves. So these are the key takeaways from the study, and we propose a uniform imaging protocol using high-resolution MR imaging of the brain and orbit, along with cranial nerve imaging using Fiesta sequence with thin sections as a mandatory requirement in all cases of isolated pediatric third nerve palsy. Thank you for the patient listening.
Thank you. Do you recommend that all these congenital cases should go neuroimaging?
Yes, that is what we have understood from our experience, doctor, because the congenital and acquired cases can have an overlap in sense of the clinical features. There can be progression seen. And
Sorry for interrupting. See, the problem is what is congenital and what is acquired. What happens, suppose a child who is 2-year-old has a palsy which is actually acquired, and he comes at age of 4 years. This may be classed as congenital. That difficulty is also there. So until you have taken cases which were congenitally present at birth, or say a month, 2-3 months, or 6 months, that risk is there that some of the acquired ones may pass on as congenital.
yes,
And
so
when you're talking about hypoplasia and aplasia, what was the size of the third nerve on MRI? Did they indicate what was the thickness of the third nerve as compared to the other eye?
So the thickness was indicated in a few scans, not in all, but the aplastic or a non-visualized cisternal segment was more often reported in the ones that cited an aplasia, complete aplasia. For the hypoplastic ones, we do not have the exact measurements for all the cases.
Complete aplasia of the third nerve would be very rare, you know. Some of these which have superior division issues, they go in for CFUM, you know, type 1, type 2. They end up more as CCDDs rather as this. And then the aberrant innervation part you were saying, if it is in congenital cases, if there is even pupil is involved, so this may not always indicate something like compressive lesion as it is in acquired. So I think that has to be kept in mind.
Exactly. So that is the reason why we said that acquired, there is an overlap between the congenital acquired cases. So to differentiate, the neuroimaging becomes very important because some of these causes can require neurosurgical intervention and radiofrequency ablation and all those things.
Yeah, I think one has to be a bit judicious because the imaging everyone is also not easy. Some follow-up that will also tell you what is happening, and if there is aberrant innervation, that usually points out to some kind of compressive lesion, you know. So if there is an aberrant, like you had schwannomas, they are very important.
Yes, slowly progressive
presentations.
lesions can also
So
end
they
up
can
with
present
aberrant
an
regeneration.
isolated third nerve. So you have not mentioned these were isolated third nerves.
These were isolated. All of these were
that is
isolated.
important because if it is non-isolated, everything becomes very different.
Yes.
Thank you for
Just one thing you said, no, there were some cases where you did not find any findings on the MRI. So in those cases, as you rightly pointed in the last slide, MRI should be done because I have recently reported a case where there is a neurovascular conflict causing isolated third nerve palsy as a congenital palsy.
Yes.
So it can happen. So you should, where you do not find anything else, go for an MRI.
No, imaging in all the cases may not.
No, sir, so where you do not find anything and you do not know
If
the
there is a reason for suspecting something, then you should do. But otherwise, I think every child to be imaged also is a bit of in our settings. If you see from Western point of view, every acquired 6 nerve they may image. We say that wait for some time, 3 months, and then take a call on it. Because if it is due to diabetes, let's say, it is going to recover. So subject everyone for MRI is also a bit loading the MRI also, you know, in our country. So one has to be judicious a bit. Thank you. Thank you so much.